My name is Sharon Keenan. I'm currently an adjunct lecturer at the Department of Psychiatry and Behavioral Sciences at Stanford University with the Sleep Disorder Center, Sleep and Circadian Science, the Center for Sleep and Circadian Science. I began my work in sleep, actually, I was interested in sleep as an undergraduate and took That's okay. And took courses in physiological psychology and cognitive psychology, and Bill Dement's name, of course, was in the literature already at that time. After undergraduate work at Penn State University, I enrolled in a course for training in EEG technology at Crozier-Chester Medical Center, which still has a program for training for polysomnography and for EEG technology. And immediately after undergraduate, I took a one-year training program in EEG technology and actually took courses at Hahnemann University. We were scheduled to do all of the neurology series at Hahnemann, which was the medical school that Crozier provided the teaching services for. So it was very rigorous training. And during that time, the neurologist that headed the sleep lab, or headed the EEG lab at that time, wanted to start a sleep laboratory. And the women who were training me in EEG technology were young mothers. And the last thing in the world that they wanted to do was to stay awake all night watching someone sleep. But I was just leaving undergraduate work and already studying sleep and already kind of very curious and interested, because sleep seemed to be that sort of place where one might gain further insights into the mind-body connection, or at least to give increased understanding about the body. One of the most important figures I can still remember from undergraduate work was looking at work that was describing the visual system of the frog. And it talked about the particular bug detector neuron that was in the retina of the eye that detected the bug, and because of that movement of that particular neuron, it then facilitated the rest of the movement of the tongue to go out into the environment to capture the bug, to provide the food. So this integration, or this relationship between these minute changes in the neurophysiology of the animal actually showing itself in the environment, I thought was very interesting and captivating. And I didn't have a specific plan about what to do after leaving graduate school, but a friend from grade school, in fact, was working as a business administrator for the neurology department and said, oh, by the way, we have an EEG training program. And then when I went to the EEG training program, they were interested in starting a sleep lab, but as I had mentioned, no one was interested in actually collecting the data. So it was a very important meeting of people who were interested in having a need of someone to stay up all night and watch the patients sleep. So I began studying patients in what we called the sleep lab. It was simply the EEG room I had to sit at the machine, and the patient was literally in the same room. Then we graduated to actually using the two-way mirror situation that existed in the inpatient psychiatry department of the hospital. We used those facilities for a while. And at one point, the construction crew came in and actually put a window in the EEG lab so that I could sit in one room and the patient could be in the other. But I tell you that piece of the story just because I think I'm not unique in having this struggle about where is the space for the sleep lab. You know, where can we do the work that we know needs to be done? So at that time and for a long time, I think people who were interested in sleep really struggled with administration and with things such as just physical space, where to do the work. The first patient that I saw in the EEG lab was a woman that came into my room to have an EEG. had actually been part of, had been being seen in the neurology clinic for about 25 years for what were considered at that time drop attacks. And as we learned more about narcolepsy, there was the question about could she possibly have narcolepsy. So she came in for an EEG study, which, as you know, is usually done during the day and is relatively short in duration as compared to polysomnography. I applied the electrodes, and she fell asleep and immediately went into REM sleep. And of course, there was discussion with the neurologist, and she was put on the appropriate medication, and her life changed dramatically. So my first patient in sleep medicine was someone with narcolepsy. So I've always been incredibly intrigued by that disorder, and I think, as we know, as we have seen with all of the beautiful work that's going on with narcolepsy, all of the insights it's providing into the working of the central nervous system. So I continued my work in the EEG lab there, and then took my boards in sleep medicine, took my boards in EEG at a time that the neurology and EEG meetings were happening in San Francisco. And you may remember that neurology and the technologist would always meet together. So the neurology meeting was in San Francisco. I took my boards in the EEG lab here at Stanford. And at that time, there was also an opportunity to visit the sleep center. So Dr. Larry Green, who was the chief of neurology at that time, and I set up a meeting. And Dr. Merle Mittler was at that time just leaving the sleep center. Dr. Lawton Miles was here. He's an endocrinologist, originally from New Zealand, was the director of the sleep laboratory when I first came here. And another person that was here was a person named Dr. Jane Perry. Now her name was Jane Skinner at that time. So the neurology meetings happened. I took my boards, and that was in '77. In 1978, the Association for the Psychophysiological Study of Sleep was held here in Palo Alto, just down the road. And that was, as you know, the early beginning society, which then had its name changed to Sleep Research Society, and then now it's the Associated Professional Societies of Sleep. And when I came to that meeting, I had the opportunity to meet Christian Guilleminault and Bill Dement and many other sleep luminaries from around the world. And I remember saying to Dr. Guilleminault, oh, Stanford is wonderful. I'd love to come here for a year and maybe do some research or help with clinical work or whatever I can do. And he said, sure, come, just come right away. We have no money. We can't pay you, but come. And I said, well, thank you. This is a lovely honor and opportunity, but, I have to eat. I have no funding, and, I can't come right now. But then a few months later, the woman that I had mentioned previously, Jane Skinner, and now Dr. Jane Perry, was leaving. She was the only technologist doing sleep studies. And her husband was doing a postdoc in Ohio, so she had to leave Stanford to go and be with her husband. And Christian reached out and said, we have funding, there's a position in the clinic, please come. So I organized with my hospital just to have a year of leave of absence, because I had every intention of going back. And I came here, and Jane left, and there were no other technologists. So Christian, Dr. Guilleminault, and I went to the meeting of the Bay Area Society for EEG Technologists, which was being held at Stanford, and we gave a presentation. He gave a presentation on obstructive sleep apnea syndrome. And we asked for volunteers, anyone interested. They already had the skills of applying electrodes and working with EEG in particular. So there were a number of people that came from that meeting, one of which was Helen Bearpark, the late Dr. Helen Bearpark, who many of people listening may remember. That's how I met Helen. She joined the team as well as a number of other people at that point that we trained, and some stayed and some left. But Helen, of course, stayed and did great work. I went on to have a PhD and did a postdoc with Mary Karskaden, and then came back through Stanford, and then unfortunately I met with an untimely death in 1996. We all miss her tremendously. So after building a team of technologists to actually help with collecting the data, gathering the data, I was doing all of the scoring at that time. We had the lab going, and we're studying multiple patients per night and doing the multiple sleep latency tests. There's lots of stories, as you might imagine, from the sleep lab that were wonderful and rich, and it was always an exciting place to work. And there were people coming, still are, people coming from all around the world to have some investigation of their sleep. Well, one of the stories was that we actually have a collection of artifacts from the laboratory, as you might imagine, simply generated for teaching purposes, obviously. But an interesting artifact was that there was an earthquake going on at one time during the multiple sleep latency test. So we have earthquake artifact in one of the studies at one time. And it was always interesting because the sleep lab at that time was in the Hoover Pavilion, which is not far from here. It's just, you could see it from this building. It was on the 3rd floor, N3B, and it usually functioned as hospital rooms, but we had one room that was dedicated to the lab room where we had 3 of the Grass Model 7 polygraphs, the tall ones with those wonderful amplifiers, 7P511s. Yeah. So there was a room that was dedicated to holding all the equipment, but then we literally had holes in the walls so that we could access those rooms, and then there was another room that had the wires run through the ceilings. But if the hospital census was too large, then we had to move the equipment to an alternative building, which literally meant wheeling the equipment into the elevator down the road, hoping that you had a truck with a lift gate so that the equipment could be moved to 780 Welsh Road around the corner, which usually functioned as a time isolation facility for the work that was going on there. The sleep center was always busy in like so many different levels and so many different areas, but the clinic often got bumped. So it was always exciting to try to make sure the studies happened and that the patients had the best care that they possibly could, especially after traveling very long distances, to have some information about their sleep. We also studied a man in an iron lung, which was impressive and a very interesting experience. The School of Sleep Medicine came about because, as a result of the development of ongoing increasing development of interest in sleep. So people would come to the clinic or come to the research center and say, oh, can I come and spend a couple of days? Or can I come and spend a week? Or can I come and spend a month? And the answer was always yes. You know, there was an enormous generosity of the team in terms of teaching and wanting to share the information that was being gathered. However, to try to maintain research work, clinical work, and also take care of the visitors that were genuinely interested, it became clear that there had to be a focus for trying to predict a time that we could give, you know, solid, critical, well-organized, structured information to people who were interested, mostly in doing clinical work. Certainly, there were those who were interested in learning from the beautiful research that was coming from here. In fact, I still have the book from the 1978 APSS meeting, and I was just looking at it the other day, and if you look at the back where all the abstracts are being listed, you know. So there were lots of people that submitted abstracts. There was maybe maximum 300 people at the meeting at that time. So there were lots of names, with individual names. But if you looked and you saw Dement, there was a Dement, and then there was a huge long list of about 20 abstracts. Mary Karskaden, the name, and a huge long list of all the abstracts. I mean, Lloyd Glenn, you know, did his PhD dissertation, you know, allowing us to understand the hyperpolarization of the spinal motor neurons is what's happening in cataplexy. I mean, it's just incredible stuff. And still incredible stuff. We could go on and on. So I digress and got stuck. I didn't, so the beginning days of the clinic, and not the absolute beginning days, I wasn't here in the 60s, I came in 78, but that was just prior to Sullivan's publication in 1981 in Lancet of obstructive sleep apnea. Krishnan and Bill had already been studying, Dr. Gilmino had already been studying patients with obstructive sleep apnea, and the treatment of choice, as you know, at that time was tracheostomy, until Colin Sullivan's publication of continuous positive airway pressure for the treatment of obstructive sleep apnea. So once that became available in the literature, of course there was need for study. And we had a very close collaboration with Colin Sullivan's laboratory. Helen Bearpark was actually originally from Scotland, moved to Australia when she was 16, married an Australian man. His name was Jim Bearpark, who worked for a huge company called Finnegan that was into mass spectrometry. I'm not going to, you know what I'm talking about. Mass spec is what everybody says. So the mass spec for the Barkas lab was just in the next building from the sleep laboratories. So Jim would be coming to calibrate the mass spec from time to time, and Helen was working in the sleep laboratory. But Helen finished her PhD, did the postdoc with Mary Carskaddon, and was on her way back to Sydney and was going to be working with Colin Sullivan to do the insomnia piece in the lab, but unfortunately was hit by a car on the day that she was to get on the plane. I mean, it's just a very sad story. But our collaboration, and that was in '96, but prior to that, in the early days, in 1980, there was the awareness, of course, and Colin Sullivan had been here, and also Ron Grunstein, as a honors medical student, came for a year and spent time, and he and Helen overlapped at this time. So there was already a richness of rapport that existed between the two laboratories. And when CPAP it was described, a woman named Kate Phillips came and spent an entire summer with our clinic to work closely with Nick Budkoff to bring CPAP to Stanford for the first time. We worked with the engineers in the basement to get all the bits and pieces, and we had all of these elaborate different size cones to be able to regulate pressure changes. You remember these things. So it was a very interesting and wonderful time, particularly with recognizing the huge benefit that this could provide for patients and their just incredible experience after the first night of sleep after suffering for so many years. So that collaboration started at that time, and then Helen continued to work with us and then went back to Sydney and did her PhD work there and then came back to the US for a postdoc. But during the time, there was a period of time between, I think, 1988, there's a period of about 25 years that I would travel to Sydney and had the honor, the distinct honor and great pleasure of working with Professor Colin Sullivan and his team at Sydney University to provide teaching. This is a course that happened in June and another one that happened in November. And it was open to nurses and physicians and technologists, and it was a 2-week training program, similar to what was going on here, but then offered there. It is true that for a long time, this school was, I dare to say, the singular resource for structured, organized, predictable training in sleep medicine. And in the beginning of that program, we would spend 2 hours or 2 weeks in a dormitory on campus. And would have lectures in the morning and workshops in the afternoon and do studies in the evening and bring all of the equipment and lots of teaching polysomnograms. And everybody would stay in the dorm and we'd do really intensive work for studying. And then also, because everyone was staying there, we'd have meals together and it was on campus. And it was a wonderful atmosphere. And wonderful, wonderful. I mean, it was the golden years, I think, for teaching and for the development of, I think, a core of a number of highly dedicated people. First, you had to be dedicated and interested to come for that period of time and to dedicate that much time. And the people who were in private practice were, you know, saying, oh, this is too much, but they still came and were still willing to dedicate that much time in terms of resources. I would say, I don't have the actual data, but I would say that most of the people who came stayed in sleep. And the day-to-day activity consisted of pretty rigorous lectures in the morning. We had a pre-test, you know, just to give them, we knew no one would do well on the pre-test. If they did, they didn't have to be there. But the pre-test was intended to give an acquaintance with the language and with the content, and to give a teaching tool so that you could take the pre-test. And we said, take it, do your best, give a guess, and then use it as an instrument as we move through the 2 weeks so that you can go back to that, because we'll have a post-test, which will be very similar to the pre-test. But these are the core features, these are the core things that we want you at least to have some acquaintance with, but also know the guidepost of where to find more information if you need. So there's rigorous didactic as well as the workshops, which allowed people to sit with the data, to actually sit with the polysomnograms. And we have pictures of one that went, you know, going and it's on top of the piano, and the wind, somebody left the door open and the wind got it, and there's a photo of it. And Dr. Palaio has a plaque on the wall that was mostly dedicated to Mary Karskadden's research that was done in that dorm for years and years. All the work on sleepiness and the development of sleep in the adolescents. The two weeks were taken up with lots of structured lectures and also workshops that included opportunities for the participants to learn how to apply electrodes, how the equipment works, what are the technical components. I think that sleep is unique in medicine in as much as that there's such an important reliance on the team that exists with the physicians and technologists, that the intensity of the technical work that goes on, time-intensive, labor-intensive, that you do need a collaborative effort to be able to move forward with the patients and to be able to provide the best service possible. But it takes the physician's willingness to learn the nuances and the underpinnings of the technology. And it's always curious to me, people coming to sleep from different fields, there's different styles or different approaches to people, to patients, I think, and to the data. And we have seen through the years that if you visit a sleep lab that's coming from a neurology-based team, you'll see lots of channels of EEG and a few channels dedicated to breathing. And then if you look at a study that comes from a pulmonary lab, you might see lots of channels of breathing and just a few channels of EEG. And of course, now there's standardization of practice, which is the most important thing that we could provide for the field. And there's more of a blending of those variables. Dr. Gilmino used to say, when people were preparing for the exam, you know, that the neurologists are always worried about the pulmonary stuff that they didn't study. The pulmonary physicians are always worried about the neurology stuff. What about those seizures? Oh my God. And everybody's worried about the kids. Because nobody sees the kids, which I think is our most important work. Sure. Again, it was a very exciting time to be involved in sleep. And it just so happened that Dr. Dement was the president of the ASDC at the same time that I was president of the Association of Polysomnographic Technologists. And he was in that role, I think, for about 12 years. I was in the role I was in for 9 years, 8 years, 9 years. And we were both here. Pardon me. So there was a synergistic effect, I think, that happened as a result of the ability just to move collectively in a certain direction. Everybody was interested in standardization of practice. You know, how can we develop an exam to be able to demonstrate competency and that everyone is doing at least a standard protocol so that we can speak about what's going on in clinic and move the field in a positive direction in terms of increased understanding of what's happening. So a lot of good things happened. I should say at the 1978 meeting, a very important thing that happened was that Peter McGregor, who was the first president of the Association of Polysomnographic Technologists, was there. Also Dr. Weitzman, he was working with Dr. Weitzman in New York. And Peter called together all the people who were in the audience who were working as technologists. And it was a lot of people working in research and a lot of people working in clinical work. When I say a lot, we're talking about a total of about maybe 20 people that were in this group. But that was a lot for that time. So Peter had the idea to start the Association of Polysomnographic Technologists. There was a little resistance at the beginning. There was some who thought, oh, the techs are trying to unionize, and that wasn't what it was at all. It really was trying to get this collective voice for people who were doing similar work, who could share experience and help. We were developing the technology at the same time. I mean, the first chapter that I wrote with Dr. Gilberto asked me, and that was the first textbook, actually. Sleeping and Waking Disorders, Indications and Techniques, I think was published in 1982, I want to say. It might be 84. But in that book, I wrote a description of how to make the respiratory effort gauges, the strain gauges, using mercury-filled capillary tubing run across the battery circuit. So it was exciting in that way that you had to come up with a gadget that was going to be able to measure the physiology that you're interested in. So that was, and I certainly didn't come up with a diagram, but we were very actively involved in actually making all of the equipment that we needed in the sleep app, except for the electrodes that were provided commercially. The APT got started, I want to say, at that meeting in 1978. It was the beginning of the Association of Polysomnographic Technologists, and it was Peter McGregor who had the insight to be able to begin that organization. And I took over as president in 1981. So he also served, a long time as president. And it was the APT that has as a subcommittee within the Association of Polysomnographic Technologists, the Board of Registered Polysomnographic Technologists. And we realized that you can't do that. You can't have the same organization providing structured teaching, information, and testing. So in 1982, at the San Antonio meetings, there was a referendum, again, started by Peter, to allow the membership to elect for the separation of the Board of Registered Polysomnographic Technologists from the APT. And that happened. And that was the way to be able to establish the Board of Registered Polysomnographic Technologists, which was already an international organization. It started as one and continues as one, so that the clinical practice could be standardized and there could be a structured set of content that people could be examined against to be able to demonstrate competence, to be able to protect patients. Always, decisions I think that we make should be driven, ideally, says Pollyanna, ideally should be driven by what's best for the patient. What is best for the patient, to make this decision, in which way? And often I think I'm not a physician, I don't suffer the fact that we see our physicians struggling each day to practice clinical medicine within the bounds of what will insurance pay for and what do I have to do to avoid malpractice, which allows for a very thin stream of practice, which in sleep especially is so sad because we know, because sleep is such a young field, that our patients are teaching us every day, and we must maintain this sense of wonder about, tell me more about what's happening with you in your sleep, so that we can, in fact, keep our thinking caps on every day as we're in the clinic, each time that we're with the patient. I know that I'm sounding like some crazy wacko, but I am saying this in a loud voice because, as we all know, we're moving in a very fast way towards precision medicine, which is beautiful and wonderful. And all of the things that our tools, as we develop, can give us the strength, the power of these additional tools, I think, is magnificent. However, we must keep in mind the patient in front of us. We must keep in mind the power of the case report. We must keep in mind the questions of how to understand this patient that doesn't quite fit into the algorithm that we've been given to be able to decide how best to help. So I think, there's beauty and wonder in the progress, but particularly in sleep medicine, because we are so young, because we have still so many questions to answer, we must continue to try somehow to keep our sense of wonder with each individual that comes in front of us, particularly the kids. Most importantly, the children. It's the most important work that we can do. To bring the recognition, the observation that something's wrong as early as possible, to be able to prevent a lot of suffering. I am biased, but I think to be a sleep technologist is one of the most exciting and interesting things to do on the face of the planet. And the research that's going on in sleep in medicine, again, I'm biased, but I think that it's a magnificent, wonderful field for research, for clinical work, and for technology. I think the technologist holds a very special role within sleep medicine in particular, because the technologist is often the person who spends the most amount of time with the patient. And it's not uncommon that sometimes certain aspects of history will come out during the electrode application process or the other times that the technologist is interacting with the patient. That can be very useful and important for the overall treatment or management of the patient. As well, the technologist has that immediate acquaintance with the data. And again, this is another place where we hope that people will keep their thinking caps on and maintain the sense of wonder. I always think of the REM behavior disorder paper with Dr. Carlos Schenk, Dr. Mark Mahoud, and Andrea Patterson, who was the technologist in the lab, whose observations, along with the other aspects of the technical team, the other people in the technical team, allowed for this increased understanding. Oh, there's movement that's happening during REM. This doesn't usually happen. What's wrong? What's happening? Why? But the ability to flag it, the ability to again, we come back to genius exists in being able to see the patterns in the data and the changes in the patterns of the aggregate. So I think that the sleep technologist has a beautiful, wonderful role in sleep medicine in general because of both their acquaintance with the patient, their time that they spend with the patient, and that closeness that they have with the data. We have to stay flexible and amend with time and use the tools that we're given, but always to question. I think, an example of the importance of the technologist is being able to differentiate artifact from real data. There's something about looking at, the story about the algorithm that's created for detecting REM. Oh, EEG looks a lot like wakefulness. Oh, the eyes are moving. Oh, the EMG is absent. So those are the rules. And you can see the data, and you can give that algorithm and have it make decisions. And if it saw eyes moving, EEG looks like wake levels, EMG is really low, all three conditions are met, therefore score REM. But it takes someone who's used to looking at the data to be able to differentiate that set of data, EEG, EOG, and EMG, from someone who is lying quietly, giving saccadic eye movements associated with reading, and the EMG signals turned off. We're at the very low levels because the tech turned it down. I'm talking analog days now, because you can hear the signals and you can't now, but you could, you should, ideally. Parentheses, another topic. But it takes another level of acquaintance with the data to be able to say, yes, it meets the rule, but something's missing, something's wrong. To ask the question, to be able to differentiate artifact from real data. What about the role of changing technology and AI for techs? I think that that this is yet another example where we have to use the best tools to the best of our ability in the circumstances, but I think that there is still a very important place, a critical place, an irreplaceable place for a well-trained clinician, technologist, to be able to supervise, to give some sense of validation or credibility to the work that's coming from the new tools. That there has to be an oversight. There has to be someone that has enough knowledge to be able to say, oh, something's funny here. Oh, it doesn't quite look right. Oh, could it be hallucinating? You know, we have to learn it. We have to use it. We have to know it enough to know when we can't depend on it completely and totally. And I think that calls for more training. That calls for an increased sensitivity to the data. And the pet peeve I have with the development, not so much with AI specifically, but with the piece in the middle that, you know, people who are really interested in the data often can't get into the black box that's been developed. And that is crazy making for someone who really wants to be able to look at the change in voltage on the surface of the skin, or to look at the change in voltage as the eyes move, or to understand how change in voltage in the brain means something. And if you don't catch the right sample at the right time, then you can't trust the overall message that's being given. So I think I'm not alone in saying, interesting, wonderful, beautiful, we must move forward in terms of, you know, development and innovation. How wondrous. But, you know, trust but verify, you know, the old sort of thing. And I think that often very, very, very busy clinicians are often kind of seduced into getting some report that gives the numbers, gives the colors, gives, you know, even a range of sets of information that then they can then say, yes, we'll go this way. You know, and it's the pressure of time. It's well understood. But I think that we can make the translation. We can make the interface between the development of the new technologies and highly skilled individuals. And that's where it works best. The most sophisticated technologies work best in the hands of an expert clinician, a master clinician. So to be able to detect the artifact, to be able to know when and how and for how long we should trust the data. Data are friendly, but we have to know, what are we collecting? What really are we collecting? You know, EEG power is one thing, but looking at changes in EEG voltages and frequencies over a period of time that give a specific pattern is another ballgame, and it's still worth playing. I think that often in sleep, my experience has been that there's been a fragmentation that exists within the different camps, groups, troops of people that work within sleep. We have the research community, we have the clinical community, and techs that are part of the clinical community, but they're a separate group, as is evidenced by the organization. So at the 1978 meeting, there were clinicians and researchers and technologists, and that's where the technology organization was born. And there was always this kind of hard to find the right words, but difficulties that exist in medicine across the board in every field that you go to. You know, the researchers have their suffering in terms of getting grants to fund their work. The clinicians have the suffering of the clinic every day. The clinic, I mean, God bless the clinic, but the clinic is hard work, and it does not stop in sleep. It is a 24-hour process. And the techs have to be there. So everyone has their suffering. And collectively, sleep suffers in general because as society is now changing, but, you know, getting set up within the National Heart, Lung, Blood Institute was a wonderful thing, but then it wasn't funded. You know, there's always the struggle, always the struggle. So that kind of inherent struggle that comes with the path that you've chosen to do your work, I think gets reflected in the professional organizations and can be flavored to a dramatic extent by not so much the members, but the executive structure of the organization itself. And that is a normal process of development and evolution, I think, that a lot of organizations go through. I think initially, the technologist organization holds great debt to, at that time, the Association of Sleep Disorder Centers, which has a little parentheses, the name Association of Sleep Disorder Centers. Maybe you know this history, but as you know, hopefully, that also is international in the beginning. And I know just from personal communication that Roger Broughton, who everyone knows, Dr. Roger Broughton, actually, when Dr. DeWitt was asking for all the donations to start the organization, we're going to have a collective voice, you know, strength in numbers, all of that. He said, you know, I'll give you my donation, but you can't call it the American Sleep Society. So that's the inherent basis of the name, the Association of Sleep Disorder Centers. I mean, there were people from Mexico, there were people from Europe, so it could not be at that point. And then things changed, of course. But when it was a small group and people were very friendly, Bill was here, I was here, you know, Elliot Weitzman did a sabbatical here and went back to create Montefiore. So there was a tremendous collaboration and cooperation. And the APT owes a lot to the Association of Sleep Disorder Center, and now the American Academy of Sleep Medicine, because it facilitated, at least gave us a room to meet during the meetings. So when things were being organized, we knew we had a space to meet. We knew that we could come together and talk about our tech things, and, you know, then it evolved into a day or a greater space and others. So initially there was a tremendous amount of support. And of course, all of that is evidenced by the fact that the APT was, you know, seated at the table. I was sitting there. I was humbled and honored to be part of that meeting. As Dr. Alan Rechtschaffen, Michael Chase, everyone at the table had their higher degrees, and I didn't yet. And I was the only tech at the table. But out of that meeting came Dr. Alan Rechtschaffen's brilliant idea to keep the APSS and change it from the Association of the Psychophysiological Study of Sleep to Association of Professional Sleep Societies. And the text could be included because we, at that time, had over close to about 500 people that were in our organization. So I think initially there was tremendous collaboration, a lot of people sharing struggles in terms of difficulty with administration to get space, to get, you know, an opportunity to work. And as things developed over time, I think that needs changed and focus changed, and there was a need for the now American Association of Sleep Technologists to establish their own organization, or at least the organization was always there, but they left the administrative support of the American Academy of Sleep Medicine. But I think above and beyond the individual organizations, there is a need for us to maintain this sense of collaboration because our voice is still small in comparison to the rest of medicine. In fact, I have worry, I have concern, because if you look at the American Board of Internal Medicine reports about the exam, the people who pass the exams, I am concerned because there's very small numbers. of people that are being board certified in sleep medicine, and the numbers of people suffering from sleep disorders, as you know, are huge. There's roughly 300 people every other year that are taking the first-time exam, and about 100 people, 150 people maybe, that take the maintenance of certification exam. And those numbers are decreasing because that cohort is retiring. So I think it speaks to the sense of urgency about perhaps the academy, the Sleep Research Society, the technologists, thinking collectively, cooperatively about how to get information about sleep, the importance of sleep, into, call me crazy, but every clinician who has contact with a patient to be able to think about sleep and to integrate that into what's happening. It's like we're working in some global ER kind of thing. The patient comes to the ER. Are you hungry? Are you in pain? We have to meet those immediate needs and comfort the patient. And I think that as long as we practice clinical medicine in the absence of knowing how this person sitting in front of us is sleeping, or how they slept 24 hours before we're seeing them, or how have they been sleeping, as we know, it contributes to our overall life experience, our ability to interact with people. One could, again, call me crazy, but I believe that the world would be a better place if people got the sleep that they need. World peace through better sleep, I want to say. World peace through better sleep. And if we look at the fact that the global leaders who travel long distances to come together, thank God that they do, it's a wonderful thing, but all of them are now suffering the stresses of travel to come together to make these incredibly important decisions in the state that we know is not optimal. But they don't even know how to get to optimal. They don't even know that they're not at optimal. This is the problem. So I think, our process of education needs to start, to begin as early on with the individual. I think it's the 10-year-olds that will change the world. We've seen that before with seatbelts. Mommy, put your seatbelt on. Daddy, put your seatbelt on. What about recycling? It was the 10-year-olds. So I think this is the place where we have to speak loudly to be able to integrate thinking about sleep, the behaviors of good sleep, to dispel the myths that we carry, to really get sleep on the agenda for every family and for certainly every clinician that's interacting, and certainly the employers who have to be able to have some degree of sensitivity, and we know we have the data. We have the data that say that if you let your people sleep, productivity will increase. This is Potash Factory, Charles Czeisler, who also did his dissertation here. I saved your dissertation, Chuck and Mary, from Bill's office. So we have the information. We have so much beautiful, important information about basic functioning. And if we look at Chiara Sorelli's work, looking at what's happening within the synapse, and we already know that synaptic homeostasis is like the Holy Grail. And that in Rome, I presented a symposium that said, in search of synaptic homeostasis, eat, sleep, move at the right time while breathing. So it's these metabolic variables that have to come together in some exquisite way to be able to maintain optimal functioning. But what we see in research often, people who are looking at metabolism, one aspect of metabolism will look at, movement and eating, but they won't look at breathing. We'll look at breathing, but they're not looking at sleep or movement. So everyone is in their silos. So I think it's taking the collective to be able to solve the problems, both the immediate problems in the clinic, the ongoing problems for research, and ultimately the problems for society. That when we have strong voices together with important data are friendly, people want to sleep, people want to be healthy, people want good lives, and sleep, I think, is one of the ultimate ways to get there. If we look at development of technology, the most exciting things are happening with satellites, batteries, and sensors. And it's sleep that can draw on all three of those incredible advances to produce what we hope to be a better life for everybody. The AASM is in an ideal position to do great things. The first thing I want to say that I'm absolutely, completely, and totally grateful to have had the experience of working in this field. I feel blessed to have had the opportunity to work in this field. I know what it is. I know what it is. I know what it is. The thing that has been most precious in this most precious of fields for me has been the opportunity to work with the people that I've worked with, to meet the people that I've met, to have developed friendships that have really been lifetime friendships. And I think that the people who work in sleep are very special in a way that I cannot describe with words. But you have to want to work hard. You have to be able to tolerate suffering. You have to be able to persevere with things that you believe in, even though you're getting no, 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 no from a lot of different places. And I think that we collectively are in a position with the tools that we have, with the people that we have, with the knowledge that we have, to be able to do some of the most important work on the face of the planet for people in terms of decreasing suffering and preventing suffering, especially if we start early with pregnant moms and the babies.